respect to elders past, present and emerging, and commit to a future with reconciliation and renewal at its heart. Thank you very much. We have, hello, good morning, Simone is online. So we have Simone Hurley, who's going to be our first speaker, and Simone will be discussing AIDA cultural capability training. Thank you so much, Simone. I'll just hand over to you. Thank you.
Thank you so much. Hi, everyone. I'm just going to share my screen because I've got a presentation. Let me go back to the start. Okay. Can everyone see that all right? Just making sure that it's come up. I can't see anyone on the screen, so if someone can just say a yes or a no, that would be great.
Yes, we can see you, Simone.
Okay, perfect. Thank you. Thank you. Okay, so I'm Simone Hurley. I am a Narangga Ngarrindjeri woman from South Australia, living and working on Kaurna country, and I am the Cultural Safety and Program Coordinator at AIDA, the Australian Indigenous Doctors Association, and I'm here today to discuss one of the projects that we're working with the Darling Downs West Moreton Primary Health Network on. I first want to acknowledge the lands that I'm calling in today, which is the lands of the Kaurna people, recognising the continued connection to land, sea and animals, and paying respect to the elders past, present and emerging. So to start off with, I wanted to give you a little bit of background around AIDA. We are the national peak organisation representing Aboriginal Torres Strait Islander medical students and doctors. We have a board of directors of Aboriginal and Torres Strait Islander doctors and a non-Indigenous doctor. We're quite a small organisation with about 15 people, majority Aboriginal and Torres Strait Islander, and our purpose is to contribute to equitable health and life outcomes and the cultural wellbeing of Indigenous people. We do this by working towards reaching population parity of Indigenous medical students and doctors and supporting a culturally safe healthcare system. Which leads into why I'm here today, is to discuss the project that we've got with the PHN. So back in 2024, the Darling Downs had approached AIDA, recognising our cultural authority in this space, and proposed a project to work together on, which is the 4 elements that you see up on the screen now. This project is specifically for the GPs and practice managers within your region. So the 2 main training elements up there are the cultural awareness and the cultural safety training. Also within there, we have pre and post workshop community yarns and a community of practice. So clinical yarning, we like to call that one. So the really unique part on here is the pre and post community yarns. This is something, a new thing for AIDA as well that we haven't carried out before. So super, super excited to see the background around it. So the pre and post workshop community yarns involves going out to local mob of general practice just to be able to have a yarn and to gain an understanding of the current cultural safety setting and local intelligence to shape the workshop to meet the consumer needs. So the pre-workshop yarns are normally done about 2 months before the cultural safety workshops, and the workshops being targeted for the GPs and practice managers within the area. So the information that's gathered at these community yarns are then collated and provided to our 2 Aboriginal and Torres Strait Islander facilitators of the workshop to be able to help inform discussions within them workshops. The post-community yarns where we go back to community about 12 months later, just to gain a further understanding of the impact and their experience in the general practice setting. So to date, we've undertaken 4 pre-workshop community yarns and we've got 2 post-workshop community yarns that are planned for December this year. So obviously this is a really unique and amazing project, and the aim is around advancing cultural safety in general practice within your regions. So really want to be able to look at reducing them health inequalities, looking at increasing the level of cultural safety in general practice to address and improve health outcomes for Aboriginal and Torres Strait Islander people, looking at building the GP capacity, enhancing consumer experience, and supporting peer learning, which is the community practice that I had mentioned earlier. The plan for the community practice is to be virtual, and we'll be looking at rolling that first one out in April next year. So to go in a bit more further detail, to give you more context around AIDA's programs, they are developed and the delivery of the programs is very unique. It's culturally informed mechanism for driving systemic change to deliver equitable and just health outcomes for Aboriginal and Torres Strait Islander people. So the program consists of the two elements, the online cultural awareness and the cultural safety. Our cultural safety workshops development started back in 2016. We rolled out in 2019. Since then, we've delivered 52 workshops to about 900 people. The online component was rolled out in 2021. Since then, we've had 4,500 people enroll. So absolutely amazing that we're able to reach that amount of people to be able to support cultural safety. So the two main elements that I mentioned before around the trainings in the project with the Darling Downs is the online cultural awareness. So this one is an online course, it's self-paced. It's an introduction to cultural safety. So it's not your basic cultural awareness 101. There's a bit more involved in it. It is the point of difference being that it has been developed by Aboriginal and Torres Strait Islander doctors. And as I mentioned, it is the entry point into AIDA's cultural safety program. It's designed for a really, really broad audience, including doctors, nurses, healthcare workers, government organisations, universities, all of which we're actively working with at the moment in delivering AIDA's programs. So the modules within there, there's 3 different modules. It's about a 4-hour course it takes to do, and it includes content and cultural awareness, the historical context to health realities, and application to health practice. There's videos embedded within there, reflection activities, and a reference list for continued learning. The second main element for the training with the PHN is the cultural safety training workshops. These ones are 8.5-hour day, so a very full packed day. The training helps participants to extend knowledge about Aboriginal and Torres Strait Islander healthcare experiences, exploring how attitudes and values can influence perceptions, assumptions, and behaviours in a clinical setting, and discussing specific ways to be more culturally aware. It's a lot of evidence-based discussions from a very strength-based approach, and includes interactive case studies throughout the training as well. It's CPD accredited, and through the evidence-based discussions, we emphasise the role of cultural safety in promoting trust, respect and collaboration between healthcare providers and Indigenous patients, driving improvements in health outcomes. Again, this one has been developed and is delivered by Aboriginal and Torres Strait Islander doctors. So the training, I suppose the main outcome around it that we want to empower people is to provide that culturally safe and responsive trauma-informed care, recognising and addressing systemic biases in that clinical setting, deepening understanding of practice through story, reflection and yarning, and building confidence in cross-cultural communications. So it's approved by specialist medical colleges, RACGP and ACRM, and aligns with APRA's definition of cultural safety, in that cultural safety is determined by the individual. As mentioned before, there is case studies, interactive yarning that's informed by Aboriginal and Torres Strait Islander doctors. It's grounded in clinical examples relevant to the GP field, and this will support the project aim I mentioned earlier around advancing cultural safety in general practice. So to date, we have delivered 2 cultural safety workshops, and there's 2 more planned for February next year, the 7th of February and the 21st of February. We really, really encourage you to reach out to the PHN to be able to book and register, because we'd love to have you come along and experience the AIDA's cultural safety training. So, as I'd mentioned, we have delivered to 900 people thus far, and looking at the impact and outcome of that through our evaluations, we know that 95% of participants have rated the training at the top compared to other trainings that they have done. 97% of participants now feel well prepared to work more effectively with Aboriginal and Torres Strait Islander peoples, and 90% of participants report their knowledge, skill and application of the learning outcomes were much improved, and 99% of participants would recommend AIDA's training to their colleagues, which is absolutely wonderful. Then I've just put on a couple of quotes that we've had from doctors, executives, board members, government organisation, universities, a whole array of people who have undertaken AIDA's cultural safety training. And that brings me to the end of the presentation, but if there's any questions or anything, we really encourage you to reach out to that cultural safety email that you see up on the screen. Yeah, happy to have a conversation, provide any more information that you might want. More than happy to have a chat. Thank you.
Thank you very much, Simone. That was really, really interesting. Does anyone have any questions while we're online now for Simone at all? If not, and you think of anything later, you can either send it through to us or the email address, contact details on the presentation that Simone's got up there. Thank you so much. Oh, sorry, collaboration space. Thank you. So we've just got our next presentation now. Simone, thank you very much.
Thank you, everyone. I will head out and let you continue. Thanks, everyone. Enjoy your day. Bye.
Thanks for making time for us, Simone. Thank you. Next up, we have Sharon from our PHN, and she's giving a presentation on My Medicare bulk billing, better access update, as well as a primary sense update. And Sharon has spoken to us before, and she is here at our Darling Downs and Westmoreton PHN. Thank you so much.
Thank you, Kirsty. Hi, everyone. Everyone's favourite topic is My Medicare at the moment, I'm sure. I've just put a quick timeline up to remind everyone we're now 2 years into the My Medicare program. As you know, we've had the GPACI, the chronic conditions management, but looming ahead on this Saturday is the better access mental health treatment plan changes and the bulk billing incentives. So today I'm going to concentrate mainly on the bulk billing and better access, because I think a lot of people have questions. Before we do that, just a reminder, as I said, it has been in place for 2 years now. So it's really time for practices to make sure that they're comfortable with My Medicare as part of the whole Medicare reform. We had some events a little while ago, or a week or so ago, with Dr. Wali Jamal and Dr. Kirsten Meisinger. And for those GPs and practice managers that might want to listen that couldn't make it, there is a very good GPs in a Pod episode. So highly recommend that you promote that in your practice. We did include it in the last newsletter, and I'll probably put it in the next one. So, you know, you need to get comfortable with your own practice's meaningful explanation, because some practices may offer priority services to My Medicare registered patients, such as scripts and referrals available by phone. Other practices might just want to pass on the message that it's formalising the relationship so the whole health system know who the patient's usual GP is. Slide. So we'll move along to the changes coming into play on Saturday. So very important to remember that there are two distinct parts to the bulk billing changes. So the first part is the bulk billing incentives is simply being expanded to all Medicare eligible patients. So the incentives that are currently available, bulk billing incentives currently available to children under 16 and Commonwealth concession card holders, just pretend that those words aren't there anymore. So nothing's changed as far as what item numbers have a single bulk bill, what item numbers have a triple bulk bill. All you're doing is saying it's now for everyone that is Medicare eligible. So if it was single, stays single, triple stays triple. And for this incentive, neither the practice nor the patient needs to be registered for My Medicare or the bulk billing practice incentive program. So this is for every single general practice, every individual GP that might like to bulk bill their patients. It's open for everyone, subject to the practice and GP's policy around it. But just remember, there are some longer telehealth consultations that are linked to My Medicare. So the second part to it is the practice incentive program. So practices that wish to participate in bulk billing PIP, they'll receive an additional quarterly 2.5% incentive payment on MBS benefits paid from eligible services, which will be split evenly between the GP and the practice. So to be eligible for that, the practice must bulk bill every single eligible service. Now, there is a really good guide. It's like a one-pager. So they're commonly known as the GP NRA items. So just all your time-based consultations, your mental health care plans, chronic condition management, and so forth. So maybe a good idea to just print that out. I've got it in the resources. It's just one page, and put it on your lunchroom table or something, just so everyone realises these are the only MBS items that must be bulk billed. And we'll talk a bit more about the other procedure items in a minute, but that's how it works. So the incentive payments will be in addition to the Medicare benefits and MBS incentives. So when this 12.5% is worked out, it's worked out on the base MBS item number, not with the single or triple incentive added on top, if that makes sense. So eligibility requirements, the practice types can be your usual bricks and mortar general practice. It can be mobile practices, outreach, sole provider, AMSs, and all those after-hours services and so forth. Essentially, the only practice type that cannot participate is the urgent care clinics. So all eligible providers, if the practice is claiming the practice incentive payment, all the eligible providers at that practice must participate and be linked to the practice in the organisation register. So that's going to include your VR and non-VR GPs, registrars, as well as locums. The practice must also be registered for My Medicare. If there's any non-accredited practices that aren't registered for My Medicare because they're not accredited, they can participate in the bulk billing practice incentive program, and they are exempt from accreditation requirements, but they can't participate in any of the other programs. And all practices that want to participate need to register via the organisation register from Saturday. So even if you've put in an expression of interest, that's not registration. You have to go into the portal from Saturday to register. And the other requirements are you must advertise the fact that you're fully bulk billing in Health Direct, National Health Services directly, and you must display the Medicare bulk billing practice signage on site to be eligible. Now, to help with that, I've just put all the resources together on how you can register on Health Direct, or if you're already on there, how to update your details. There's also a link there to the signage requirements. And at the moment, the signage that the department have done, all it says is this practice bulk bills. They didn't put like the little explanation. There might be some procedures that are privately billed. So apparently they are going to do some new signage, because there was a lot of backlash about that, because a lot of patients would be confused because they'll walk into a practice and then they'll have a procedure done and then get told that there's a gap fee. So in the meantime, Cubico have actually done up, it's not branded Cubico, but they've done some really useful ideas on extra signage. So as long as you put the department signage up, you can add your own signage around that, as long as you're displaying that you are a bulk billing practice. So some other considerations, after I have a drink of water, is 1st of November is just a commencement date. So you can opt in later, you can backdate up to 180 days, and you can opt out again. So don't panic if you do want to start bulk billing on the 1st, but you have the person that can get into the org register is away for a week or something, you can just backdate it. So the initial incentive period is November, December, and the incentive will be paid in January, but it will be quarterly thereafter. So January to March, April, June, July to September. So it doesn't totally line up with the other PIP payments, because this is a separate incentive paid through the organisation register. And that's why it's important to have all your bank account details, and for all the GPs to have their bank account details in their HPOS, because it's not linked to your, QI incentives and things like that. So it's probably worth thinking now, because I know the department will probably be advertising the fact that these bulk billing incentives has been expanded. So if your practice is still deciding, probably recommend you utilise the calculators on the website, encourage all of practice discussions, and make sure you include everyone, owners, GPs, clinical and administration staff, and maybe think about what your messaging will be to patients in the interim, because I'm guessing you may have people come in assuming that they're going to get bulk billed. If you've already decided that you are going to participate, you just need to make sure that you register in the organisation register from the 1st of November, and that you do follow the NHSD and signage guidelines. And there's also going to be some forecasting tools in HPOS. So you'll be able to go in during the quarter and find out if, some item numbers were accidentally private billed and things like that, and you'll be able to amend that. And also just see how you're tracking for the amount of the incentive. And you'll also be able to get your reports on the previous incentives. And I've got a link to a guide that will show you how to do all that. If you're a practice that are definitely retaining mixed and private billing, probably a good idea to have clear messaging to your patients on that value proposition for all your staff to confidently communicate, so no one's put in a difficult position explaining. So, other considerations. There's a lot of words in this presentation, sorry, but hopefully I'll cover it all for you. There's been a lot of questions around claiming errors. As I mentioned, there is a forecasting tool, and you can make those retrospective changes to previously lodged claims, and you can even amend in previous incentive periods. The department apparently are going to be, well, they call it administrative arrangements, are going to be in place for when you cannot bulk bill an eligible patient. And that, could be because they're a newborn baby, they don't have a Medicare card number yet, newly arrived migrants or overseas visitors and so forth. So if you can't legitimately bulk bill at the time of the service, it doesn't mean you're going to forego your whole bulk billing incentive payment for the whole quarter. They won't kind of tell us the actual margin, like I don't know if they're just going to say, oh, well, if it's within 5%, we'll just pay it and follow up the ones that have slipped through. Not sure, but there is going to be a lot more information be downloaded onto the department site on Saturday, and they're going to do a lot of case studies around these types of scenarios. But it's not going to be hard and fast that, whoops, someone didn't bulk bill, the whole practice has lost their incentive. There will be things in place to make sure that you still get paid. But obviously, if it was happening all the time and it was a big margin, then you might be audited to find out why that's happening. So here's some links to resources. The program guidelines are out now. So there's a link to those. There's a link to the calculator. The e-learning module covers both how to register and how to forecast your payments. So recommend you look at that. The eligible services, which is that one pager that you can download. And there's also a frequently asked questions, which the department is continually adding to. If you haven't already, Cubico have partnered quite closely with the department and like Services Australia and RACGP, and they've done some amazing webinars that are all recorded. And because there are so many scenarios, as in you're a practice that's chosen to bulk bill, you're a practice that's mixed, or you're still deciding, as I mentioned, there's different webinars that focus on your different scenario. And there was also one yesterday, Countdown to November, and it was purely on questions that people are asking, and it had about 4 people from the department in it, and they were all the people from the policy around the whole bulk billing incentive. So highly recommend that you look at some of those webinars, and they're really easy to watch because I don't know if a lot of you probably know Chris from Cubico, and he's pretty good at webinars. I think my screen changed. Sorry about that. So that's bulk billing. So the next exciting thing to talk about is the Better Access Mental Health Care Plan changes, which are also from the 1st of November. So there is a lot of confusion around this because one of the changes is that it should be the patient's usual medical practitioner that the patient who has provided the majority of services to the person in the past 12 months, or who is likely to provide the majority of services to the person. And this could be their My Medicare registered provider, but it may not be. So it is not linked to My Medicare registration at all. So unlike the chronic condition management plans, whereas if a patient is registered to a practice, that's the only practice that can bill for the plan, it does not matter with Better Access mental health care plans. So they can be registered with one practice and go to a different practice as their usual provider of their mental health support. So that is all fine because it's their usual medical practitioner for those purposes. Oh, what did I do here? Oh, sorry, disappeared off my screen. So the next big change to that is the removal of the review and consultation items. So the preparation MBS items remain the same. So they haven't changed at all. It's just the review items are all gone now, and you now need to use the time-tiered general attendance items to review, refer, or provide ongoing consultation for a patient's mental health. Now, this has probably been a source of a lot of discussion because it's going to be a lot more difficult to know if a patient has had a review and so forth. But as it stands, that's what it's just the normal consultations that will be claimed, and the review will just be contained in the clinical notes. It's also going to be encouraged for patients who require at least a moderate level of support, use the Better Access treatment services, and where intervention using the Better Access initiative is not appropriate, to consider other interventions or pathways. And it's also going to align the telehealth requirements for mental health treatment plans with the usual requirements for face-to-face services, with those services no longer exempt from the established clinical relationship rule, which I think is a face-to-face in the last year. But the focused psychological strategy treatment services provided by GPs will continue to be exempt. That's for those GPs that have that additional training. So we don't have, aside from knowing those broad changes, we don't have a huge amount of resources because apparently on Saturday, this is when there's going to be lots downloaded to the government site, to the department site. But in the meantime, there is a document around the MBS changes under Better Access Initiative from the department. And there is a webinar from Cubico. And hopefully yesterday we actually sent out kind of an alert to all the practices with an MBS guide as well for better access mental health care plans. So you should have received that yesterday. But what I'd like to emphasise is please read the newly designed In Practice newsletters, because that's how we get all this information out now. So we're going to do, because a lot of the resources are going to drop on the weekend, we've provided you as much as we possibly can to date. But next week we'll be doing another edition, because obviously the expression of interest is going to disappear and you'll have to order your signage a different way if you're participating. There's going to be lots of resources for the Better Access mental health care plans and so forth. So we're going to do a special My Medicare edition next week. So look out for that. Other than that, they come out monthly on the opposite fortnight to Health Professional News. So if you're not receiving it, reach out to your PCLO and ask them to make sure that you're on the distribution list. You can always, reach out directly to your liaison officer with any questions, and if they're not sure, they can refer them on and we can get back to you. You can email practice support with any questions, and all our newsletters, including In Practice, are all uploaded to our website, so you can look at any previous editions quite easily. And we're also undertaking to keep the My Medicare site up to date with like little tiles that you can go straight to, whether it be chronic condition management or better access. So we're doing our best to make it easy to find these resources, because there are just so many. Sometimes it's overwhelming to just get to the one that you want. So if you've got any ideas for us on how we can make it easier, please feed it back. But other than that, I'm done, unless there's any questions. Or I will note I've got to leave the office because I've got an off-site visit, so I can't hang around. But you can leave. And I just was going to give an update on Primary Sense too. Yes. But can you just look? I can't see the question. I think there's a question popped up.
Oh, okay.
Or can someone? I can probably exit from my, but I'm not in the Teams.
That's okay. I'll just have a look for that while we're doing this. Questions? Okay, in the chat. So we've got from Anand, it's currently all MBS payments are deposited into the clinic's account and GPs are remunerated on a fortnightly basis. How will the new incentive be paid? Will it be directed to the clinic and the clinic responsible distributing the next relevant share to the GPs?
Okay, so that's actually a good question, because it's a good reminder. There's two parts to this. The bulk billing incentive, ignoring the practice incentive, so just your normal bulk billing incentive that's made currently to under 16s and concession card holders. Nothing changes with that except it's expanded. So however that works now, it will work the same moving forward. It's just expanding eligibility. For the practice incentive payment, the 12.5%, that comes 50-50 split. So it's 12.5%. So what's that? 6.25% will go into the practice's bank account, and 6.25% will go to the relevant GP's account for their patients that they've bulk billed as a fully bulk billing practice. But for the normal incentive payments, nothing has changed. It just means that more of your patients are eligible, and you might find GPs, just because it is higher, even if the practice doesn't want to bulk bill everyone, you might find the practice does bulk bill a lot more than they do now because of that expanded eligibility. Hopefully that answers the question. Is there any more? Because again, I can't see. Sorry.
There's no more that I saw there. Oh, I think there's
Oh,
another
there is
question.
another question.
Oh, okay. Just bring it up. Thank you, Kate. So let me just see. Oh, the next question is, how do I ensure the GP has been granted the necessary access roles to view their entitlements?
Okay, so if you go to that guide in the HPE site, I've put a link into it that is an educational guide. If you're having trouble accessing in that, just reach out to us. But it's through HPOS, so if they've got HPOS access, they should be able to quite easily look at that. So you'll be able to, as a practice manager, be able to look at the whole practice and then individual. Oh, that's a good question too. It's in their personal details in their HPOS. So if they go into HPOS, I think there's just down the left-hand side, personal details, and it'll go bank account details. And again, happy for anyone to reach out if they're having trouble finding these things, but there are good educational guides in that HPE site. So I recommend that you use that a lot. And it's also got screenshots in it, but you can also click on an accessible version that will give it all to you in stepped out in Word version. But I'll make sure that when we do our in practice newsletter next week that is devoted to my Medicare, I might try and put some direct little links to those common things that people might need to know. So, but it's not hard. Now,
thank you for that. We'll take any further questions. If you put them in the chat, we can get back to you after the meeting on that.
Yeah, cool. Thank you. Before I hand you over to Pete, I'm not going to take up much time talking about Primary Sense, but just in case some people have heard on the grapevine, this PHN is shifting from the PenCat data extraction tool to Primary Sense. So Primary Sense is a PHN owned data extraction tool that pretty much nearly every PHN in Queensland is now using. I'm pretty sure. And a lot of quality improvement activities are being built around this specific tool. It's very easy to use. You can easily extract reports. You don't have to use recipes. They're all predefined. You don't have to log in. It's just on your desktop, and it's pretty much live within 2 hours and so forth. So just wanted to flag that you will get some communications probably before the end of the year with a few details where we've got a few practices that we're going to kind of test it a little bit with first to make sure our processes are as easy as possible for the transition. But you will get some more information on this before the end of the year. But be rest assured we won't take PenCat away until it's embedded properly. So that's all I wanted to say about that. And I'll hand over to Pete.
Sorry, guys, I'm just going to steal a quick couple of minutes. So I'm Peter Wallace, Director of Primary Care, so I work with these guys fairly regularly. I just wanted to actually ask and get some feedback from all of you. So next year we're partnering with RMEA. We're looking at doing sort of a course, well, a series of courses that are sort of micro-credentials that are aimed towards practice management and medical admin staff. So what we'd love to hear from you guys is what topics might be important for you at the moment, what you'd like to see within that. So I'll read a couple of topics that are sort of being suggested to give you a bit of an idea of the flavour. And if you could give us any feedback via our practice support email, or we'll circulate a survey that we've sent out previously around education requirements again, probably in our next newsletter. And then, yeah, let us know. So some examples are frontline cyber defence, so cyber security awareness and prevention for non-technical staff, making your practice visible, marketing digital presence for clinics, closing the route, recall results and follow-up systems, building safe workplaces to respect boundary and legal responsibilities. So that kind of gives you a bit of a flavour of some of the subjects or some of the micro-credentials that we've been looking at putting in place. The plan at the moment is to do this over the course of next year, so we very much welcome any feedback that you may have between now and then, so that we can kind of shape it to what you guys need on the ground. So that's me. I'll jump out and bring Kirsty back so she can introduce the next person. Thank you.
Thanks, everyone.
Thanks,
Bye.
Thanks, Sharon. Thank you very much, everyone. Next, we have Dr. Rachel Claydon, who is a GP for Mater Refugee Complex Care Clinic. And Rachel will be talking about refugee health and catch-up immunisations. So I'll just let Sharon sort of move out, and then I will.
Thanks, Kirsty.
Thank you.
I'll just try and share my screen, shall I? If I fail, I might ask you. Oh, you've got the slides ready. Do you want to just? Are you happy to do it? And
Whichever suits you.
it's probably easier, isn't it? Thank you. Do you want me to get started, Kirsty?
Yes, thank you.
Okay, and I'll just shout when you So so I'm Rachel Claydon. As Kirsty said, I work as a GP at Mater Refugee Complex Care Clinic, and essentially our clinic is funded to see people seeking asylum who don't have Medicare. But I also have a non-clinical role with the Refugee Health Network of Queensland. So I thought it was worth today just really briefly telling you a little bit about the network, but also around, refugee health in Queensland and refugee background arrivals that you are probably already seeing in your clinics, and you might be very familiar with this, but for some of you it might be new. So the Refugee Health Network of Queensland is a statewide network, and it really exists there to sort of support clinicians across the state and also community and supporting organisations in delivering effective and best practice refugee healthcare. But one important role of our group is that we have the Primary Care Clinical Advisory Group, which meets around 4 times a year, and it really is there to support the primary care space, particularly GPs, practice staff, practice nurses, practice managers in this space. And Darling Downs West Moreton PHN comes along, and as well Elizabeth Lavity, I think I can see you in the room there, Liz, and who is the Refugee Health Officer with in Toowoomba, that some of you probably know, who supports people accessing care, among many other things, and also Amal Hussain, who is funded by the PHN as a refugee health nurse in the Ipswich region. And I just thought, looking at that slide, there's no links on there, but if you do look at our network website, there's a lot of resources on there. So information for GPs, nurses, but also practice staff, and lots of translated resources and appointment reminder tools and things like that you can look at. Thanks, Kirsty. So just for those of you who are not aware, Australia has a humanitarian settlement program. So we will settle people from refugee backgrounds in Australia and provide them with settlement support. At the moment, Australia settles around 18 to 20,000 people per year. Queensland, we have roughly 3,000 arrivals each year. And you will know that Darling Downs, West Moreton, certainly Ipswich, Toowoomba, Gatton, all of those regions are fairly large settlement areas. And just to point out that the 5 main settlement areas across the state, you can see them listed there: Cairns, Townsville, Darling Downs, West Moreton, Brisbane, Logan, Ipswich, Gold Coast. So all of those areas have refugee health nursing services. So they will make contact and see new arrivals when they arrive and sort of triage and plan their health needs. But the bulk of care, in fact, I would say all of the care sort of beyond that occurs in general practice. So it really is a role for general practices in this space. Thanks, Kirsty. Oh, and just to flag as well, sorry, a little pop-up came on that last one that we do see a lot of women and children. And at the moment, I think 50% of arrivals at the moment are less than 25. So lots of young people arriving in this space. Thanks, Kirsty. So it's recommended that everybody after arriving has a thorough health assessment. And some of this will be commenced or started by the refugee health nurses, but the bulk of it then is done by general practice and GPs and practice nurses in community. And this is guided by Australian refugee health guidelines. There's a practice guide that people can access. Some of you probably already know that refugee health assessments, you can claim an item number under the health assessment item numbers, you know, the 701, it's up to 707, I think, and also claim in consultations that time taken when engaging an interpreter. A really important part of this, and what I really wanted to focus on today, is catch-up immunisations. So we know that most people arriving will have incomplete vaccinations. Some people may not have had any vaccinations or may not necessarily have documentation. And it's important for us to also think about the adults. So I think in general practice, we're really good at vaccinating kids and thinking about the kids, but I think sometimes we tend to forget the adults. Thank you. Yeah. So the recommendations are, actually, if you can just flip back, Kirsty, thank you, to provide catch-up immunisation so that people from refugee-like backgrounds coming into Australia are immunised to the equivalent of an Australian-born person of the same age. And there's often a bit of confusion around adults because, as you know, catch-up's funded for everyone else, I guess, up to the age of 20. But for humanitarian entrants, people of refugee backgrounds, refugee-like background, it's funded. So under, you know, the NIP program of any age, you can complete catch-up vaccinations for free on this cohort of patients. So you might already be familiar with this, but there is a whole chapter, and it's actually quite a useful chapter in the Australian Immunisation Handbook around vaccination for migrants, refugees and people seeking asylum in Australia. And it talks through the recommendations, and it reiterates again that catch-up immunisations are free and can be accessed under the NIP for these patients. Thanks, Kirsty. And it's not very clear on here, but I have put a link. I think you might all be very confident with catch-up vaccination. I still sometimes get a little bit overwhelmed, especially when people might have some documentation. Maybe it's not clear, I'm not always sure where to start. So there is a special infographic as well in the immunisation handbook that's quite helpful. We have that up on our wall at work, even though our nurses are really used to doing this and creating catch-up schedules, but we do have that up on our wall and find it really helpful. Next question. So one question that people often ask is, what about written records that people may come with? So we do consider that an acceptable and reliable evidence of vaccination status. I mean, provided it can be read clearly, provided that it makes clear sense. And I guess if you're not sure, then it's better to start the complete catch-up again. And in the absence of any documentation, we would always say start up a full catch-up immunisation is the recommendation. Now, sometimes people will come with records, obviously in not in English. So there's a couple of options. We will, usually talk to them and say what you can do. They can access a free translation service through the Department of Home Affairs. That's one option. It can take some time to get those records back, but that is an option. I think I've provided a link. Sometimes, though, people with discussion are quite happy to restart and do a full catch-up. So it really is case by case and just talking to people about that. Thanks, Kirsty. So, and I guess one thing we will often see, and you've probably seen this as well, that looking at overseas records, often, even though the vaccinations have been given and all of the doses received, there can be some differences in recommended dosing schedule. So again, looking at that, if the intervals seem to be too short or it's not clear, again, safest thing to do is just restart, do the full catch-up. And one thing we notice with people that have recently arrived, some of their vaccines may have been commenced by refugee health nurses. Sometimes as well, they may have seen a few different providers and may not necessarily be sure what they've had in terms of vaccination, or may not have been given a written record. So always checking air, but I'm sure everyone checks air before going ahead with those anyway. And again, just as a reminder, I think we're all fairly familiar and have the kids at the forefront of our mind, but and we all know, I'm sure, about the catch-up calculator online. That's really helpful for catching up for kids' vaccines. But there is as well in the immunisation handbook an infographic and just some tips on catching up the adults as well. And reiterating again that I can't remember the data off the top of my head, but looking across Australia, we do know that people from refugee backgrounds are very much under-immunised, kids including adults. And I think if we're looking at situations now as well with measles outbreaks, women planning pregnancy, really important that we get this catch-up done. Thanks, Kirsty. And some people ask around whether we would do routine serology to detect people's immunity. It's not recommended to do routine serology for a broad range of vaccine preventable diseases. We do say absolutely hepatitis B serology should be done first to check if anyone has an underlying chronic hepatitis B before immunising. And obviously we suggest varicella serology as well in the adults because the likelihood is that they've already had a varicella infection at some point. In the kids, we say just go ahead and follow the usual catch-up schedule. And we would always suggest checking a rubella as well. So particularly in terms of women who may be planning or may become pregnant. Great. So I've just popped a few resources up there, and I think the best resource, if you're not sure if somebody may have been immunised, you can reach out to your local refugee health nurses, and certainly in Toowoomba, Liz, I think reaching out to you would be a great first step, and then Amal as well in Ipswich. And I think if you don't have contacts for Amal or Liz, surely you could reach out through the PHN. I've also put on there the Australian Immunisation Handbook, just that link to the vaccination for migrants, refugees and asylum seekers, and the Australian Refugee Health Practice Guide, which is an excellent, really easy to use resource that covers lots of things, not just immunisation. And there's also tips in there for admin staff, practice staff. And then Refugee Health Network of Queensland, that link will take you to our section on immunisation. It's not a huge section, but one thing that's really good in there are the translated resources. So you'll see them in quite a few different languages that really explain what vaccination is in simple, easy terms that you can give to patients as part of that discussion. Thanks, Kirsty. Thank you. Any questions?
If anyone thinks of any or needs the contact details for the Toowoomba and Ipswich links, please contact us on Practice Support and we can forward those questions on or give you the contact details. And you can also put them in the chat. We've just got a few minutes left. So thank you so much, Dr. Clayton. But we can take any questions on advisement and get back to you if you think of some later on as well. Thank you. I'll just see if anything's popped up in the chat. No questions in the chat. So thank you so much for your time, Dr. Clayton. And thank you everyone for attending. So we'll end and we'll have our next meeting probably in March of next year. So we'll be in contact for that. So enjoy the end of the year, everyone. Thank you.